guys. Thank you, everybody, for coming, and thanks for having me. I know she said save questions to the end, and I don't want to break the rules, but if you really do have a burning question, and just really do stop me. It does not bother me if you have a quick question. I intentionally shorten these slides a little bit so we can have more discussion at the end, because I think that this is a critical topic. I'm speaking tomorrow in the breakout session too, so I really tried to split reproductive health in general into two areas. So today I'm going to talk about can we preserve fertility and pregnancy in Turner syndrome. And tomorrow I'm really talking about ovarian aging and really across the lifespan in Turner syndrome. So I'm kind of splitting it up into two groups. So that's really what I hope to talk about today. I have no conflicts of interest. So, what really is fertility preservation, right? So what do I mean, can we preserve fertility? It really means two things, in my opinion. It means, can we, and this is specific to Turner syndrome I'm talking about, can we freeze eggs, right, to preserve the biologic ability to have a child, right, using your own egg? It also means, can we preserve the ability to carry a child, which is important in Turner syndrome. Because if you have years of hypoestrogenism, the uterus shrinks down to a prepubertal size, and we'll talk about what that means in pregnancy, regardless of if you're using your own egg or someone else's. And that's an important point too. So it's not just preserving the ability to use your own egg, it's also preserving the ability to carry a pregnancy later on. And I think both things are equally important. We used this term the oncofertility and fertility preservation term started in the cancer world years ago, really in the 90s, and it took off. And really we've moved that to autoimmune diseases and genetic diseases, and now we've moved it to just ovarian aging, because now we have tools to understand where an egg pool is today, and I'm going to talk about that a little bit in the talk later. So just sometimes I'll have a 32-year-old come in and she had a screening for her egg pool reserve and it's lower than it should be and she just wants to freeze her eggs. She doesn't have any condition that means we would expect it to be lower, but it is, unfortunately. And whether or not there is something genetic we can't identify or it's the environment, which is a whole other talk in itself. I often give talks on the role of the environment and plastics and pesticides and PCBs and where we are in the literature. But then finally what we're seeing is elective egg freezing. Women pursuing careers, not finding Mr. Right, not deciding when they want to build a family, and there's a whole movement of elective egg freezing because egg freezing has gotten so much more successful. So why fertility preservation in Turner syndrome? Well, as probably everyone knows in this room, Turner syndrome is loss of all or part of an X chromosome. One of the things that we still debate is, most of the time Turner syndrome diagnosis is based on a blood draw, right? So it's a blood draw, it's a karyotype, it's where the white blood cells are tested, right? To see if they have two X's, one X, a whole X, and part of another X. The problem is we don't know if whatever that same level of mosaicism is at the ovary, is at the heart, is in the lungs. We don't know what it is on each individual tissue level, and we still are really trying to understand that. And there actually have been studies, even though a woman may be 45X in the blood based on white blood cells, we may find low-level mosaicism, say, in the ovary or in other organs. So we still have a lot to learn. We see accelerated egg loss. So oocytes are eggs, and we think it's really due to abnormal meiosis. The easiest way to explain this is, right, so when you make an egg, when a man makes a sperm, he or she can only send half of the chromosomes off, right? So each of us get a chromosome, say chromosome 1, chromosome 2, chromosome 3, and even the two X's. We get one from our mom, one from our dad, right? So the problem is if you're going to pass on genetic information from both your maternal side of the family and your paternal side of the family, what has to happen is take chromosome number 1, for example. The two chromosomes line up, and then in order, when you're getting ready to make an egg or a sperm, they have to recombine. They have to mix up because you can only send one. And the only way you can send information from both sides of your family tree, those two chromosomes have to mix up. If there's only one X and it has nothing to pair with, then it can't do its normal mixing, right? So you can't create a normal amount of eggs, and so that pool starts off abnormally low and it gets depleted more rapidly. And that's really why we think in Turner syndrome there is a lower number of eggs or a more accelerated rate of loss. Does that make sense? So if we look in general, we think ultimately a little over 90% of women with Turner syndrome, doesn't matter if it's mosaicism or not, are going to end up with early menopause, right? Early ovarian failure. The average age of menopause, and the definition of menopause is when the menstrual cycles stop, right? And the ovaries are no longer really working well. The average age in the US is 51. It is considered early menopause before 45, and it's considered premature ovarian failure or primary ovarian insufficiency before the age of 40. Over 90% of women with Turner syndrome will have ovarian failure before the age of 40. More specifically, probably only about 40 to 50% of girls will start puberty on their own, which means their ovarian failure will be before the normal age of puberty, which on average is somewhere between maybe 9 and 12, okay? And really only probably about 10% or so are gonna start menstrual cycles on their own without medication, okay? So that's really, if you look at global statistics, and really before we truly understand the mosaicism at the level of the ovary. The couple things I'm going to touch upon, I'm going to go into this a little more tomorrow, but if needed, hormone replacement therapy, meaning estrogen initially first, is often started around age 12 if puberty hasn't started. And there's a balance between not wanting to start it too early because it can close the growth plates, right? And often we give growth hormone and we're trying to increase the total height. So we don't want to give it too early, but it's balancing it with the time that we also want to help. That's a critical time when you're depositing calcium in the bones, and you need that. You need estrogen for long-term bone health. And then ultimately, after about 2 to 3 years of gradually increasing it, you don't want to increase it too fast, and you don't want to start progesterone too early. But after about 2 to 3 years, progesterone is then added in so that regular menstrual cycles start occurring. Without estrogen, the uterine size either stays prepubertal, or if you're on estrogen for some time and then you take it away, the uterine size will regress. I'm going to talk about it more tomorrow than today, but there is a difference when we say the word estrogen. It's really tricky. Birth control pills have a synthetic estrogen in them. They're good for the heart, they're good for the bones, they're not great for the uterus, okay? So there are different formulations of estrogen, and I'm happy to go into that further either in the questions or tomorrow as well. So one of the most interesting things is women never make new eggs after birth, after actually being a 20-week fetus. We don't make new eggs. Men make sperm every day. Men start making sperm about age 13, and they make sperm until they die. And so we don't make new eggs. Now, it's a fascinating process that we do not really understand. This is not in Turner syndrome. This is just average female, and this is put together based on sort of thousands of autopsy specimens, just dying of natural causes, you know, being a 90-year-old and dying natural causes, dying of a car accident, donating organs. It's counting the individual follicles and eggs in the ovary and understanding what this pool looks like, really from in utero till the normal age of death. And so what you see is at about 20 weeks in utero, you have a maximum number of eggs, which is thought to be about 3 to 4 million. By the time you're born, we've lost about 80%. We're down to about 750,000. And this is with 2 X's, okay? At puberty, we're down to about 300,000. Menopause occurs when you're down to about 1,000, irrespective of your age, right? So, I mean, I had an 18-year-old in my office this week, not with Turner syndrome, not previous chemotherapy, radiation, just unfortunately in menopause. We don't know why. 90% of the time, actually, 1 to 2% of the general female population presents with early ovarian failure, and we don't really know why. Turner syndrome is the #1 genetic cause of premature ovarian failure, or primary ovarian insufficiency, but most of the time we don't know why. we think when you're down to about 25,000, you can no longer really get pregnant. The most important message I always try to say to everyone is just because you're having a menstrual cycle does not mean you can get pregnant, okay? Menstrual cycles, if they're on their own, not with medication, are a positive prognostic factor for still having some egg pool left. However, you will have menstrual cycles 5 to 7 years before menopause when pregnancy cannot be achieved because there are very few eggs left, okay? So menstrual cycles do not equal normal fertility, and that's an important message too. So we have these little eggs that sit all around the outside, and this is obviously a cartoon drawing, and this is a real histologic sample. So you see all these little, tiny little follicles. So follicle, by definition, is a little fluid-filled tiny cyst where an egg is inside of it. So they sit all around the edge, which is important when we talk about can we freeze an ovary, okay? So these are growing follicles. And so these get closer to the blood supply as they develop, and it takes a very long time for these little follicles to develop into big follicles. We know that the X chromosome is critical with regards to determining what the egg pool is. And if you are missing all of an X chromosome, there are numerous genes that we still don't understand on the X chromosome. The X chromosome is actually one of the hardest chromosomes to study because there's a lot of repetitive regions and a lot of what we call ampliconic regions. So it's really hard to study compared to all the other chromosomes. But there are critical regions on the short arm and the long arm of the X. So a woman can have one normal X and one X where maybe just a tip of the long arm or a tip of the short arm is broken off. And she maybe was never diagnosed with Turner syndrome as a child, later on. And the debate is, at what point do we call it? If it's just a tiny little distal break, she may present actually with recurrent miscarriage or early menopause. To me, somebody like me, and I'm drawing a karyotype for the first time in her life, right? So we even debate right now, and actually I think we're talking about it on the panel tomorrow, is what low level of mosaicism of 45X in the blood we even use to define Turner syndrome, right? Kind of where is that cutoff? So we know the genes on the X chromosome are really important. So how do we know how many follicles are left, right? So I told you we've used autopsy specimens, and it's not really we. Carl Hansen in Oregon has really done one of the lead studies on this. And ovarian reserve screens are our best option. So the term ovarian reserve was coined decades ago in the world of in vitro fertilization, where we learned that there's these blood tests that can really tell us how a woman would respond if we gave her medicines to stimulate her ovaries to retrieve eggs. And what we've learned over time is one of these blood tests, AMH, anti-Müllerian hormone, is one of the best tests we have out there to understand what the egg pool is doing today. Now, it's incredibly tricky because you can't just go to your primary care doctor and say, hey, order an AMH, because they're not used to interpreting it. And the assays are very different. If it goes to a Quest, if it goes to a LabCorp, if you draw it at the hospital and they send it out to ARUP, they're all very different assays. They're getting better in the United States, but they're all very different assays, and you have to understand those assays a little bit. AMH, and this is going to be talked about more tomorrow in the ovarian reserve across the age span, but it really is present at birth. It goes up in childhood, it plateaus in the early 20s, and then goes down for the rest of a woman's life. We use it in everyday infertility patients. We use it in the fertile population now with a little less data, but to predict that egg pool and decide about elective egg freezing. And now we're using it in a variety of genetic conditions, and Turner syndrome is just one of them. Women with breast cancer mutations, BRCA1 and 2, we're learning that those mutations also impact the egg pool. And we're looking at AMH in those women too. And it can tell us a lot. I work with the Turner syndrome clinic in both of our children's hospital, and I follow girls of very young prepubertal age with AMH. And I'll follow serial AMHs every 3, maybe even every 6 months, depends on where it is, because I'm watching for it to start to change. It really should be going up at that age, right? If it's staying the same, if it's starting to go down, I'm really starting to get concerned that egg pool's going fast. And it's trying to determine when and if to intervene to try and preserve fertility. We also have started gathering data on ultrasound. So in an adult woman, we would do a vaginal ultrasound where we would measure the ovarian volume and count these little pea-sized follicles. In a young girl, if she can have a full bladder, we actually, with the good ultrasound machines we have now, can see the ovaries still and often still count the follicles. So we have more and more data on a transabdominal antral follicle count, but there's only a handful of us in the country who've done some of those. So if you look, there have now been a couple studies correlating a blood AMH, so this AMH test is literally just a simple blood draw, and looking at karyotypes. So if you look at girls and women who are mosaic, so 45X and 46XX at varying degrees, 77% of them, and most of these were teenagers or post-pubertal girls, AMH was detected in 77%. So the lower the AMH, the lower the egg pool is, okay? It's kind of opposite if any of you have already dealt with FSH, follicle stimulating hormone, which is made from the brain. FSH talks to the ovary. The higher the FSH is, the less the egg pool is, okay? So those two are a little bit opposite. And then though AMH in the same age group was only detected in 10% of girls and women who were exclusively 45X, and well, at least on their blood draws, okay? So the less mosaicism, the more likely you are to have earlier onset of ovarian failure. So how do we preserve fertility, okay? So if we even want to, how do we do it? So we're at a point right now, it all depends on the age of the patient. So if a woman comes to see me, so by woman right now I'm saying 18 and older, okay? So an adult comes to see me. If she's in a relationship and we have sperm, the most tried and true, highest success rate, standard of care is freezing embryos, okay? Those are fertilized eggs. Because you know there's only a portion of eggs that are mature, only a smaller portion of those are going to fertilize, only a portion of those are going to grow to day 3, which are 6 to 10 cell embryos, and only a portion of those are going to grow to day 5, which are 150 to 200 cells embryos. You know, I always joke that we humans are not very efficient reproducers. We never have been, and we never will be. So what's really changed in the field is this, which is really the reason I'm even here talking. The oldest IVF baby, maybe you've seen it on the news lately, she flew in from England and was at our big meeting in June. It was all over the news. Louise Brown is her name. She's turning 39 this week, actually, is her birthday. So IVF has been around for over 4 decades. We've been freezing embryos for nearly 40 years. We've been attempting to freeze eggs. We've been freezing eggs, and I say attempting because it hasn't been the most successful early on since really the early 1980s. The first live birth from a frozen egg was 1986. So it's been around a while. The problem is we used to try to freeze eggs like we would freeze embryos, which was initially a slow freezing method. Well, an embryo is a ball of little tiny cells, and it would always freeze better. An egg, a mature egg, is one big cell that would get a lot of ice crystals in it, and it would never freeze well. And so the success rates per egg were very dismal back in the 80s, and really in the 90s. It was really in the late 90s when a new technique came along called vitrification, which basically is taking eggs and it's like the most ultra rapid cooling system you can imagine. It's almost like an immediate glass-like state. It changed the field tremendously. And that's what's really opened the door that young girls, women, you name it, in whatever situation can start to consider freezing eggs instead of freezing embryos. You know, if I had a young patient come to me even 10 years ago, and I remember these conversations in clinic, I'd say, and even when I was at Washington University in St. Louis, we had an experimental protocol, but the standard of care was freezing embryos. And these poor single women would be handed a sperm donor catalog and say, maybe pick one and we can fertilize these. Nobody wanted to do that, right? And so we really are in a much better place today. So we basically were under experimental protocol for about 10 years. And then really in 2012, our American Society of Reproductive Medicine all got together and said, all right, we have accumulated so much data that egg freezing is safe that it is now the standard of care. We're removing the experimental label. Spain already by then had hundreds of thousands of births by frozen eggs. You know, in the US, we're a little bit slow to adapt. But there was enough data to say that egg freezing was safe. And that's where we are today. One last thing that will come up, and especially in Turner syndrome patients, is do you freeze ovarian tissue, okay? Ovarian tissue means that we don't stimulate the ovary. So when I say egg freezing, I mean freezing a mature egg, and that's tricky because a mature egg is one that's ready to ovulate. The egg that I ovulate this month started recruitment from those tiny little follicles I showed you on the edge 8 months ago. So to go from a tiny primordial egg that we would freeze if we freeze ovarian tissue to a mature egg that would ovulate and be ready for fertilization is an 8-month process. We haven't figured out how to do that in the lab, okay? So that is why we have to give girls and women injections for a 10 to 12 day period to stimulate the ovaries and have these follicles grow so we can then retrieve mature eggs, because that has the highest success rates, right? And so, but if I have a 5-year-old, I can't stimulate those ovaries. The oldest, okay, let's put it this way. The youngest girl I have ever given injections to stimulate her ovaries is 11. And the reason is, there was one that was turning 11 that week. And the reason is you want them almost to be post-pubertal, because then the ovaries are waking up. If you try to stimulate a pre-pubertal girl, those ovaries are not ready to wake up. Those eggs have not started that 8-month process that I just started talking about, right? So this egg freezing can really only be done in the post-pubertal, not post-menarchal, so meaning breast development has started. It doesn't have to be having menstrual cycles, right? Once menstrual cycles start, they're even easier to stimulate. They're a little trickier after breast development, but it's still doable, okay? If you had a 5-year-old, the only option would be ovarian tissue freezing, and I'm going to talk about that and the pros and cons. Many are not doing it in the country because they still feel it's way too experimental. So, like I told you, the first live birth was in 1986. So when we go to thaw eggs, so right now you can keep eggs frozen indefinitely. I get that question a lot. How long can they be frozen? The longest an embryo has been frozen and used for a live birth is 20 years, okay? Egg freezing has really not been used that readily that long. So there are, unfortunately, probably more females and women that have eggs frozen than have used them at this point, okay? But they've definitely been used. Pregnancy rates now in many studies, so even just women who are going through in vitro fertilization, there were early studies where they agreed to say, all right, we're going to freeze half of our eggs, fertilize half of our eggs fresh, and we're going to look at pregnancy success rates. And there have been numerous studies now to show that the frozen egg compared to the fresh egg has equal pregnancy rates, okay? And so, and we've looked even at the genetics of a frozen egg versus a fresh egg, and we see no difference. So, have there been egg retrievals in girls and women with Turner syndrome? Yes. Most of them around the country have been in those who have some mosaicism, okay? But again, and even if you're 45X in the blood, it does not for sure tell you what you are at the level of the ovary, okay? Probably, yes, it is 45X at the level of the ovary. But we've definitely seen girls and women where we think there actually may be mosaicism there. What are the better prognostic factors that would suggest you would respond better and do well with egg freezing. If you started puberty on your own without medicines, and that includes even starting menstrual cycles without being on estrogen, if there's some mosaicism, if the FSH stays low or the AMH is higher or measurable, those things suggest a better prognosis. One guy in New York this is one publication of a handful. Really, there are 3 patients in this study of his, and this is just one down here. But this was back in probably 2008. So this was when, about 2005, we were at a meeting and these case reports were starting to pop up, and they're much more common now. But this was when there were 3 patients, 13, 14, and 15 actually. They all were mosaics. They all had an AMH that was still measurable. It was not 0. Now remember, AMH will hit 0 years before menstrual cycles will stop. So that was a positive prognostic factor. They all went through ovarian stimulation and had mature eggs frozen. There's one thing I'm not going to go in too much today, but this is also still a little bit experimental, but it's being used more readily. When I say mature eggs, that's mature eggs that I retrieve at the time of the egg retrieval. There's this kind of just barely immature stage where they're not quite there, where we think we can culture them for a few hours or up to a day or 2 in media with nutrients, and if they mature, then we can still freeze them, and they may still have very reasonable success. So that's what I think we're going to see used a little more readily than ovarian tissue freezing for at least some time. So everybody asks me how we retrieve eggs. There's no incisions anywhere at all. Basically, the way we retrieve them, it's about a 15-minute procedure. So, patient gets an IV, it's sedation. It's propofol sedation in most clinics, like you would get if you got a colonoscopy, right? You're not intubated, little nasal cannula, and it's a 15-minute procedure. And the way we get eggs is usually a needle goes through the vaginal sidewall and right into the ovary so that there's no incisions. So just like a puncture site, just like if you get your blood drawn, right? At the top of the vagina on the right and the left. Now, in order to do it accurately, you do it with a vaginal ultrasound so you can see exactly where your needle's going. So the younger virginal girl, that vaginal ultrasound may slightly stretch the hymen. The vaginal probes have gotten better. But it's something to think about, right? That's usually the question I get a lot. But we make sure they're very comfortable and completely asleep before we ever do an egg retrieval, okay? And when they wake up, they may feel a little bit of vaginal soreness. Their ovaries feel a little crampy, but basically with very little medication, usually like a Toradol, which is a sister to ibuprofen, and I rarely even need to give narcotics in recovery. They do great and are home within an hour. So it's very straightforward. This picture just shows you the probe going here into the vagina. This here is what I'm almost looking at on the screen, and I can see the needle come in, and these are fluid-filled follicles that were growing over that 10 to 12 days of stimulation with medication. This just shows you, here's this small microscopic egg that's in that follicle. This is the needle coming in, and I'm literally just aspirating that fluid. I have a test tube, I'm handing it to my lab director who's sitting on a big microscope talking to me. We have 1 egg, 2 eggs, 3 eggs, so I know exactly what we're getting as I drain each follicle. So this is the big question, in my opinion, in Turner syndrome. When should we do it? In a perfect world, you want to wait a little bit. You want to let her have a little bit of maturity, right, and understand what's going on. 15 is probably a little better than 11, right? However, if the egg pool's declining too fast, then you probably can't wait till 15. So it's driven by that AMH. You don't want to wait. If you've waited until the AMH is 0, now, if I stimulate the ovaries, I'm lucky if we get 1 egg. Going back to my line that we are very inefficient reproducers, it takes about 6 to 8, 6 to 10 eggs per live birth. So is it useful to go through to get 1 egg? It's personal choice, but the success rates are going to be much lower, okay? So you really don't want to wait until that AMH is 0. So it's tricky. The other thing that comes up, and I collaborate, we go to a quarterly meeting with all the pediatric endocrinologists, is if we stimulate the ovaries for a brief 10 days, and there's a rise in estrogen, am I somehow going to close those plates in the bones just a little bit and counteract the growth hormone and getting maybe 1 more inch of height, right? It's tricky because really that estrogen's only up for a few days. So there's discussion right now about using a protocol. So I also freeze eggs in young women with breast cancer. So if there's an estrogen positive breast cancer and we want to keep the estrogen low, we can use a pill medicine called Retrieval that keeps the estrogen levels low even though the ovaries are growing these follicles. So there's some debate on whether we should do that or not. Usually my hope is we get them to a point where they've been on growth hormone for a while. They're probably at a point they want to start estrogen anyway in there, right? And so we're at a point where it doesn't matter if we have a very short increase in the rise or increase in the estradiol or estrogen level. So here's one other thing I get asked a lot. So if you have Turner syndrome, are all my eggs going to be abnormal, right? Are they going to lead to more chromosomal abnormalities? If my egg pool is low, will the eggs be more abnormal? And I get that question a lot too. In the non-Turner syndrome population, if we look at couples, and we've looked at this data nationally now, that are doing genetic testing of embryos for some reason. They've had recurrent pregnancy loss, they carry a mutation in something, they're carriers for cystic fibrosis, whatever it is, and we look at abnormal chromosomes. We know that as women increase in age, the quality of the egg goes down, right? And this is the non-Turner syndrome population. So we know that as women cross probably the 37 line, the miscarriage rates go up, and the percent of embryos that are chromosomally abnormal goes up. And they dramatically go up after the age of 40, okay? Now, over time, and the numbers have been going up, we've seen a little bit of a U-shaped curve, meaning the younger you are, so if you're 16, 17, 18, non-Turner syndrome patient, and having a pregnancy, there's a little bit of an increase in abnormal chromosomes there too. So it's extreme of ages, right? So one of the questions becomes, now if we're freezing at 12, right? I mean, could there be more chromosomal abnormalities? So there have been a couple situations in patients that are mosaic for Turner syndrome that have gone through IVF and genetically tested the embryos, and we are seeing a higher percentage of chromosomal abnormalities. So right now we are assuming and advising, if you freeze eggs at a young age, when you go to use them, 15, 20 years, and you put sperm with those eggs and those embryos develop, you may end up wanting to genetically test them before you transfer them if that is something you choose to do. Now, we're at a point in the field of IVF where you can do that very easily. When an embryo has 200 cells, basically there's an inner cell mass that develops into the baby, and then the edge is what develops into the placenta. You can pull 4 or 5 little cells off the placental edge and not harm that embryo at all and do genetic testing. So we've come a long way in the field and trying to make it so it's less invasive, less harmful to the embryo, and the testing itself has gotten better. So that still is what is advised in the future if you do freeze eggs, okay? So what are some things that I do consider as pubertal status, like we talked about, remaining ovarian function, and psychological maturity? Those are things that, I usually talk with the parents about when I have young girls, prepubertal girls, pubertal girls, premenarchal, postmenarchal girls. Now, last few slides here on ovarian tissue cryopreservation. So here's my ethical debate, and this is what I struggle with most. if 45X and the AMH is already low at 5, 6, or 7, it's possible we may not even get to a point where we can stimulate the ovaries and freeze mature eggs. So you may want to consider having one ovary removed and freezing what we call the ovarian cortical strips. Those are the little strips on the outside where I showed you where all those tiny eggs are. The problem, in my opinion, is I've seen sometimes pediatric surgeons remove an ovary in someone who has a very measurable AMH and may have had normal puberty and menarche on her own. Think about what I said, we don't make new eggs. If at birth we have even 500,000 eggs in a normal state, but in Turner syndrome, let's say we have 200,000 and I just took one ovary out, now what happens? Now we have 100,000 left. And now she may be less likely to go through puberty on her own. And so I struggle with that. Are we doing the wrong thing by pulling out an ovary and freezing it because it's so experimental still? You want to try it, but I struggle with that. And that's me. There are some practitioners out there more readily taking ovaries out, but it is something that I think we don't know the answer. We definitely have had a number of young prepubertal and postpubertal girls with Turner syndrome that have had ovarian tissue frozen, okay? It requires a surgery, usually a laparoscopy, hopefully not anymore an open surgery. A laparoscopy would take a couple small holes, but it's a surgery, general anesthesia, intubation, and you have to resect that ovary, clamp the blood vessels, and take the ovary out. The purpose is not to culture that tissue in a dish. The purpose is, let's say she's 30 and now she has no normal ovarian function. She thaws this tissue and that tissue's put back in the ovarian bed of the ovary that's still in her body to try to make that tissue grow again. That's why it's frozen. What are the concerns? When you thaw this tissue, it doesn't last very long in some cases, and it's been done actually in cancer patients too. And there are about 50-ish live births worldwide from frozen ovarian tissue. The issue is some of those patients probably still had some normal ovarian function in their ovarian bed when it went back in, so we debated a little bit. But some actually have had pregnancies. Sometimes there's so much scar tissue there you still have to do IVF, but the tissue strips don't often last as long. They're hypoxic, and when they are thawed and put back in, the follicle loss is really accelerated for some reason. So probably you have a year or two of life on those cortical strips. So I've told you most of this. Actually, there are a couple cases, not in Turner syndrome, but other patients, and I even did one in a patient who had cancer and she was 25 and had no time to stimulate her ovaries. I actually gave her 2 days of medication because that's all we had. Normally it takes 10 to 12 to get mature eggs. So in the OR, because it was a GYN cancer, it was a very malignant cancer of her uterus, they were going to remove the ovaries anyway. So if they're going to remove them anyway, then we were going to try to freeze the tissue. And at the time of the removal, I had a needle and I was aspirating the small pea-sized follicles just to see if I could get some eggs at that time that were already maybe 7 months in the 8-month process. And we did this in vitro maturation, but it's still very experimental. So, at the end of the day, I believe we're doing the right thing because, it gives women a chance to have autonomy, to have biologic children with their own eggs, hopefully down the road in certain situations, okay? The problem is sometimes there's lower success. The last thing you want to give is false hope. So you have to really have a very clear conversation, in my opinion. What are the success rates? How many can we get? Is it worth it? And what's the cost? Many insurances don't cover it, right? Sometimes they do. There are some programs and grants out there. So the last couple slides are on pregnancy, okay? So spontaneous pregnancies are overall rare in Turner syndrome, okay? It's been quoted to be, in the best study we have now is probably 5 to 6%, okay? Most of those patients have mosaicism, that have spontaneous pregnancies, which goes along with everything we've learned about ovarian function in mosaicism. At the end of the day, it's critical that patients desiring pregnancy have thorough aortic and cardiac evaluations before they conceive, okay? An MRI in a center where they understand how to adjust the aortic root measurement based on stature and based on body surface area and all of those things. You can't just do a random MRI and get a read at a hospital that doesn't know how to change those measurements, in my opinion. Even if everything's normal on this, there's still a little bit of residual risk because it goes back to we don't know on a tissue level how many cells are 45X and how many are 46XX, right, in each organ, including the aorta. So the other thing that's come up is a woman with Turner syndrome, if she conceives with her own eggs, there is an increased risk of miscarriage for two reasons. Number one goes back to what I said, that we think we're seeing an increased rate of aneuploidy or abnormal chromosomes in the embryos and in the pregnancies, okay? The second reason is because of the uterine environment. And what I see are lots of women who've had years of hypoestrogenism. And it takes a while to get that uterus to the point where it's really well vascularized for pregnancy. And sometimes women come to me because they know they have ovarian failure. I have 3 patients right now going through, 3 women all in their 30s with Turner syndrome that were 45X, and they had ovarian failure early on, and they used estradiol to go through puberty, and then they were placed on a birth control pill, and they were on that birth control pill for 20 years, and now they want to use a donor egg. The problem is their uterus is very prepubertal in size. And I have to take them off that birth control, and I really have to rebuild that sort of uterine size for a while before they go forward with pregnancy to give her the best outcomes. Using an egg donor is a very viable option, okay? Because we can freeze eggs more readily, there are now frozen egg banks, just like there are frozen sperm banks all over the country, where you can get an anonymous frozen egg, and it's just like, so sperm banks have been around for 50 plus years, right? I mean, egg banks are now popping up in the same sort of process. You register, you look online in the privacy of your home, you go through, you find someone who looks like you, has similar likes, dislikes. You can try to keep that process completely anonymous. And in certain situations in these egg banks, the eggs are already frozen and ready to be released. So you may say, all right, I'm purchasing these 6 eggs or these 8 eggs, and they're shipped to a clinic like mine, and then we basically get your uterus ready. We thaw those eggs, we put them with sperm, let the embryos develop, and transfer one excellent quality embryo to the uterus. I would almost never recommend transferring more than 1 embryo, right? Because the risk of multiples goes up and the risks in pregnancy go up dramatically, especially in Turner syndrome. In a singleton pregnancy, the cardiac output goes up basically, I mean, 10-fold at minimum and possibly even more. So there's stress on the heart and aorta. But it's a very, very viable option. Some come in and want to use a sister or a cousin or a friend. That's very doable also. There's a little more psychosocial evaluation required. There's a little bit more required in the legal contracts, okay? But it's a very viable option in certain situations. The last thing is, even in women using an egg donor, we're still seeing in bigger studies an increased risk of miscarriage. And we really think it's because in a lot of studies, a lot of standard IVF centers who weren't used to working with women with Turner syndrome or long-standing ovarian failure, they would just throw them on estrogen for 2 weeks, wait till the lining thickened and go forward, but not look at the uterine length, the muscular size, and other aspects of the uterus. And we think that's why. What other risks are specific to women with Turner syndrome? More hypertensive issues, so more high blood pressure, preeclampsia, eclampsia in pregnancy, more thyroid dysfunction in pregnancy, so you need to be followed more closely, more risk of C-section, and truthfully that's probably because the general OBGYN gets nervous of labor and stress on the heart and the aorta, okay? And that's really the main thing. There's more low birth weight and prematurity and more preterm labor, and maybe that's because of the uterine environment. The most important thing is if you look at national statistics, maternal mortality, if you carry the pregnancy and you have Turner syndrome, can be as high as 1% to 2%. And really that's because of the risk of aortic rupture, which is why I stress the need for a very thorough evaluation pre-pregnancy, right? And a thorough discussion about those risks. And that is why there are some women that come in and they want to use a gestational carrier or a gestational surrogate, meaning someone else's uterus to carry the pregnancy. No matter if it's your own eggs that you had frozen or a donor, you can still do this, okay? Very doable. I have 3 patients this week going through using a gestational carrier. Very doable. Last of the 2 options are embryo donation or adoption. There are occasionally couples out there, not very often because we don't make a ton of leftover embryos, but occasionally couples that maybe had a child or 2 and have a couple embryos left and their family is complete, and they donate these embryos to embryo adoption agencies or embryo directed donation agencies. And these do exist. There are not many of them, but they do exist out there. And then finally, adoption. Adoption in the US, there are public and private adoptions, there are directed adoptions, there are international adoptions. Adoptions are still tricky. Obviously, you have to be screened. The average cost of adoption is often $30,000 to $50,000 in the United States. So it's not a cheap option either, right? But they're all viable options for building a family. And I feel like it's important to always talk to patients about all of them. So with that, I'd love to take questions. I know it's a lot to take in, but I'm hoping I told the story okay. So thank you. Mm-hmm.
So if a girl is started estradiol,
Yeah.
low dose, is this, you're out of luck at this point, or is it still a possibility?
So you mean like age 12, 13, starting estradiol? 11, 12, yeah, to start puberty, to start the progression.
Yeah, so low dose estrogen.
So yeah, so odds are that if they started the estrogen at 11 or 12, they probably drew an FSH that was already on the high side and didn't think, she had a lot of ovarian function left. It's usually less likely of an option because, and probably if you drew an AMH, it's going to be 0, right? Now, so using and freezing your own eggs is probably less likely of an option. You still can evaluate with ultrasound and AMH and look, because there are sometimes situations that are a little different, but usually yes. Yes, ma'am?
Does classic versus mosaicism come into play in that same?
Yeah. Because in classic, you're much more likely to have ovarian failure before the normal age of puberty, which is why by the time you hit that 11, 12 mark, an FSH is high and we're starting estradiol. So that is very much part of the story. Yeah.
What's the measurability range for an AMH test, and what's the ideal measurability number that you should be looking at for harvesting?
Yeah, it's tricky. I'm going to show slides in my session tomorrow with a bunch of AMH numbers. Even those slides are on a certain assay. Here's the problem. Like, we use the ultra-sensitive AMH assay machine in our office, so I can run an AMH in 45 minutes. Your pediatric endocrinologist can send off an AMH, but maybe they send it to Quest or LabCorp, and it gets frozen, it gets sent out, and they all have very different ranges. In general, in most assays in the US, the AMH is going to start in the 1s or 2s in a young girl, go up, probably be 3s, 4s, 5s, and if you have, that's sort of in the 20s. 5s is kind of getting up there, but if I have a 20-year-old, I'd be happy in the 2s or 3s, okay? I'm following girls right now that are 7, 8, 9 that have an AMH of 0.9, but it's holding steady. It should be going up every time I measure it. At 7, 8, 9, every time I measure it, that's when you should have a linear rise. Between 4 and 8, it should be going up. So it's tricky, but it's not dropping, and I'm trying to get her to at least the point of puberty so that she's a little bit further along. So, but if some of the older assays can't measure below 0.3, and it is important if it's 0.2 or 0 because it tells you a lot. The lower it is, the fewer eggs you would probably get if you stimulate the ovaries. So yeah, in the back. You, yes.
I was just looking at your chromosomal numbers, and I'm wondering, do you see those girls with ring chromosomes or supernumerary rings with their rate points having a less viable?
So where there is one normal X and one ring, one isodicentric, yeah. So yeah, usually, and I do follow several patients that have one normal X and one isodicentric X, or one ring, and so they do tend to have a higher egg pool than classic Turners. Sometimes they do. So I think it's important and worthwhile to draw like an AMH and look at that. Yes?
So the goal, since ovarian failure happens earlier in Turner syndrome, the goal is to take the egg down and freeze them before the ovarian failure occurs?
You got it. It's trying to do it proactively before it occurs. Yep. Yes.
This might be more of a cardiology question.
Uh-huh.
What is your opinion on the risk with Turner syndrome women for pregnancy with bicuspid aorta?
Yeah, it's usually probably, if it's a bicuspid aortic valve, you mean, usually I've taken care of patients who've been pregnant and done just fine. Okay, if their aortic root is not dilated, if everything else is fine, their ejection fraction's normal, there are very little things going on. I have specific cardiologists I refer to in all the St. Louis area that I know will do all that correctly. See, that's the thing that's important, making sure it's all, you have to adjust for all these measures. You can't just go with the standard rates of, what are the measurements of the aortic root and all of those things. But in general, it's very doable. I mean, that's why I also think it's important. I send every patient of mine who's pregnant with Turner syndrome to a high-risk OB. So I help get them pregnant, and after about 12 weeks of pregnancy, I hand them to a high-risk OB. So they're followed very closely. Yeah, yes?
My question is, what recommendations would you have for like 7 and 8-year-old girls? Where should we start?
Yeah. Yep. Yep, I'd flat out just start with just a blood AMH level. To me, that's the most helpful thing you can do. Because you know what? If it's already 0, it's telling you that potentially even if her FSH is low, if that's been being measured by the pediatric endocrinologist right now, but that AMH is really low, odds are that FSH is soon to go up. AMH usually reaches 0 several years before FSH goes up. Okay, but if it's 1.5, 2 point something, that's very promising. And I'd probably follow it personally. I'd follow it at least every 6 months. Sometimes I follow it every 3, yeah.
Just to follow up on that, so when we had our first ultrasound,
Mm-hmm.
we didn't see any ovaries.
Mm-hmm.
Is that typical?
No, because this is at what age?
7.
No, I mean, you can't even, I have 2 daughters, and I've brought them in because I had a study with girls with autoimmune diseases going on, and I used them as controls. I couldn't see their ovaries at 7, 8. You can't, no, not at all. Most sonographers, they have to have a super powerful scan and really know how to look for ovaries. So that's not uncommon at all. In the back, yeah. Uh-huh. No, it's actually a great question, and there is some research going on, and there are some things happening outside the United States that are not FDA approved in the United States right now. The problem is you probably need a little bit of ovarian tissue to use and biopsy to then find these, what we call egg cell precursor cells. That's what they're looking for, and that's what they're trying to use. And it's been used in Canada and in the UK and in UAE right now, and there's a couple studies going on. But if her ovaries are gone, right, yep, How many, can I take any more? Okay, how about this? I'm going to follow the rules. I'll stay up here for a little bit if anybody wants to come up and ask questions. So thank you.